Hello and welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to work off of a paper. It's from 2018. It is in the International Journal of Osteopathic Medicine. The paper is called, or titled, Core Competencies in Osteopathy, Italian Register of Osteopaths Proposal. So the point of this particular paper, again, keeping in mind that it's an editorial, is to put forth some concepts that were developed within the Italian Register of Osteopaths in order to possibly be a guide not only for European jurisdictions, but other jurisdictions around the world. And I'll read and comment as I often do. So to read first, background. The concept of competence is central to the professional system to ensure practitioners possess an adequate profile that enables them to effectively perform their role. In this editorial, we build on the concepts of competence and clinical reasoning to propose a core competence framework for osteopathy in Italy, which can inform current legislative development and future professional training and education. Apart from the specific context of Italy, this framework may also play a critical role in the development of professional education and regulation worldwide. The aim of this editorial is to initiate critical discussion on the topic of professional competence amongst educators, regulators, and practitioners in the field of osteopathy. So this is from 2018, and once again, it seems as though Italy, broadly, is for some reason attempting to push forward or lead with respect to frameworks and guidelines for osteopathy. So the 2010 World Health Organization document, Benchmarks for Training in Osteopathy, was really much more centrally a Government of Lombardy document that was adopted by the World Health Organization. So really that document, that Benchmarks for Training, or what many people call the WHO document, that put forth the type 1 and type 2 schools, for whatever reason, that was the region of Lombardy's government. Now, again, we have the Register of Osteopaths the Italian Register of Osteopaths. Let me say that properly. They are putting this forth. Now, as I noted when I've spoken about the WHO document, it was an hours-based curricular document with nothing with respect to assessment protocols. The CEN document and the CSA document, they've updated and added a little bit with respect to assessment. I would say that they could do a better job with respect to assessment, and I can leave it there, but there has been some development across time moving towards a competency-based framework. The WHO document is definitely not a competency-based framework. It's an hour-based curriculum, and that does have challenges. This seems to be at least an attempt to move towards a competency-based framework by putting forth suggested competencies. How will I do this? I don't need to do that. I'll read from here. So reading further on in, competence is based on clinical skills, scientific knowledge, and moral development. It includes cognitive, integrative relationships, and affective moral functions in the process of patient care. In contrast, competency is related to the use of a structured set of knowledge, skills, and attitudes in a specific professional context or in professional training. So to pull out of reading, they're talking about the term competence and competency and comparing and contrasting so that people can understand the difference when they're reading certain literature. So to go back on it, competence, so being competent, is based on clinical skills, scientific knowledge, and moral development. Okay, whereas competency, a competency, essentially would probably be described best as a category that includes a set of skills and behaviors and whatnot. Is that fair? Yeah, that is fair. Okay, competency is related to the use of a structured set of knowledge, skills, and attitudes in a specific professional context or in professional training. So the competency itself is, say, more specific. Being competent is a little bit more broad. Having a competency or displaying a competency is a much more specified thing. Let's put it that way. So I think that's fair. To read again, therefore, professional competence is more than a demonstration of isolated competencies. It is the ability to manage ambiguous problems, tolerate uncertainty, and make decisions with limited information. In the health professions, professional knowledge is centered on the application of core knowledge through clinical reasoning, incorporating scientific, clinical, and humanistic judgment, and metacognitive strategies which enable practitioners to identify and address gaps in their knowledge and use external resources such as evidence-based practice. So I think that's quite a fair statement, quite a fair definition. Competence is the integrated, maybe to reframe, competence would be an integrated demonstration of sub-competencies and then the ability to apply those to ambiguous situations, problem-solving type situations. Those ambiguous situations and problem-solving type situations is one of the reasons cognitively with respect to educational strategies that I prefer and advocate for a FAR transfer paradigm, where you're teaching to the ability to transfer problem-solving schemas, causal relationships, things of that nature, or stated another way, the omnipresent features that are there and non-tangible, non-visible, but they're consistently present in all of these varied circumstances. So when I say something like contact is control and control is safety, no matter what an osteopathic practitioner is doing, no matter how they're interfacing with the practitioner, or with the patient, the table and their contact with the patient are the things that are going to allow both for effective treatment and maintenance of safety and relaxation of the patient, such that it is always there and the details will vary. So a patient who is seated will need more contact from the practitioner to keep them safe because they have less contact with the table. Things like that. It's omnipresent. It's not necessarily tangible, but it's always there and always guiding you. Getting into the clinical reasoning portion, clinical reasoning has a variety of discussions around it, some of which are based on challenging underpinnings. So when you talk about metacognitive strategies, that doesn't necessarily mean that they're pointing in this direction, but when you see metacognitive strategies in literature, in research literature, it's often pointing towards things like cognitive forcing strategies, cognitive debiasing approaches. Those don't work because they're based on the assumption that the person committing an error or committing a mistake in thinking that they don't know they're making can correct it. Unfortunately, that doesn't seem to work. The thing that seems to work better is expertise, and expertise is essentially predicated on increased knowledge, increased skills, and essentially longer-term mistake making or mistake commission that has been noted and corrected through increased skills and increased knowledge. So there seems to be an art and a time required for that. So I just note that because it's possible that the authors of this and the Italian Register of Osteopaths may fundamentally be working from a cognitive debiasing, cognitive forcing strategy to create metacognition. It doesn't really seem to produce the results that one would want. So I don't know that that's the case, but I put that out there as a possible caveat. Sorry, I'm just scanning really quickly. Please excuse me. Yeah, so what I'm going to do here is read what they've written about clinical reasoning, at least in the background portion. So I'm going to read clinical reasoning, including its underpinning cognitive, metacognitive, and perceptual processes, build on the foundation of EBP competence. Traditional models of clinical reasoning in the health professions build on the best evidence available, and they refer to a cognitive, practitioner-centered process whereby practitioners gather information about their patients, evaluate that information, develop treatment and management plans, taking into account relevant research literature and clinical guidelines. Clinical reasoning is a critical capability in autonomous professional practice, and it draws heavily on professional knowledge and decision-making strategies that are specific to each health profession. Consequently, pre-registration and post-qualifying education and training of healthcare professionals should be based on the core competency profile profile required for that specific professional context. Regarding osteopathy and considering the specific case of Italy, recent developments in legislation designed to regulate osteopathy as a health profession require the development of a document that clearly defines core competencies in osteopathy. This document would then become central to osteopath's professional profile and training in Italy. The statement that I'd like to highlight here: clinical reasoning is a critical capability in autonomous professional practice, and it draws heavily on professional knowledge and decision-making strategies that are specific to each health profession. That is about as accurate and abstract a statement as one could make. This is building towards essentially working off of previously existing frameworks, because when you're going through an administrative regulatory process, regulators really like to see stuff that looks like what they've already seen, under the possible assumption that what they've already seen is both valid and reliable as far as the process for building competencies. And maybe it is, maybe it isn't, but this paper is essentially, again, an editorial building towards, these are the reasons why we did it. It's going to look like these other things because of the regulatory structure. But in an abstract way, clinical reasoning being autonomous professional practice, drawing heavily on professional knowledge, decision-making strategies. The decision-making strategies lines up well with the framework that I advocate for of a FAR transfer paradigm that are specific to each health profession. Now, the FAR transfer paradigm being specific to the health profession of osteopathy, the heuristics that I've put forth, so context is control, control is safety, relational motion, one thing stays still, one thing moves in relation to it. Table makes stable, less stable means I need to make the patient stable, the space between us is unstable, things of that nature. Don't make them say ouch for the barrier concept. Those would be specific heuristics that would be FAR transfer paradigm methods that are going to help osteopathic practitioners work. The primary one that's really going to differentiate osteopathy from other healthcare professions, especially hands-on professions, is the barrier concept. Don't make them say ouch. And what we're really looking for there is the opportunity to guide practitioners in avoiding protective responses in the patient, or generating protective responses in the patient. I'm going to read again. Osteopathy offers a patient-centered system of evaluation, treatment, and management that can be applied across a wide range of medical conditions. I will stop there when it says medical conditions. I will say that in most circumstances that's inappropriate, especially to guide other regions, other professions, things of that nature, because in other areas it's not a regulated profession. Regulation may not be coming. So there's a lot of things that are not available to osteopathic practitioners. And osteopathy historically will claim that it is not medicine, that it is not allopathic terminologically. So osteopathy treats the person, not the condition, especially in unregulated circumstances or in unregulated jurisdictions. So I would be really careful with that term for any others who would be looking at this. But when you're looking at a regulatory framework coming forward, you're going to scaffold off of previous frameworks. The one that most regulators are going to think that they understand is going to be the medical framework, so I understand why it's in there. To read again, it is traditionally based on the principle that the structure and functions of the body are closely integrated, and the person's well-being requires the neurological, musculoskeletal, circulatory, and visceral structures to work in harmony. Authors in the field of osteopathy argue that application of osteopathic principles, of structural diagnosis, and the use of osteopathic manipulative treatment in patient care is what differentiates osteopathy from other professions. I will pause there. Other professions will have models, right? They'll have principles that are very, very similar in word, in thought, and in action. So I don't know that I would say that that differentiates osteopathy. The use of OMT, or hands-on treatment, it doesn't necessarily differentiate osteopathy from other hands-on professions. The actual applied approach, reliant on the barrier concept primarily, not on cognitive interpretation of findings, but the actual application of the barrier concept is the thing that I would say, as an actual observable construct, is different in osteopathy. It is why osteopathic practitioners will move differently at different speeds than other healthcare practices or hands-on practices. So I'll leave that for now. Leave that. Yeah, I'm going to read here. In some countries, the osteopathic practitioner's approach to diagnosis and treatment is underpinned by 5 models of structure, function, interrelationship, i.e. biomechanical, neurological, metabolic, respiratory, circulatory, and behavioral models. I'll pause. Those are interpretive models. Those are cognitive interpretive models post hoc. They are after findings. They are not before. Okay, to read again. These models can be used in combination to provide a framework which enables practitioners to critically evaluate the significance of somatic dysfunction or other clinical findings obtained through both objective and subjective clinical examinations. Again, those models are applied after findings, right? So that's essentially what it's saying. You can interpret, critically evaluate is what they say, but I will say interpret, so that maybe you could grab onto that more. Authors in the field of osteopathy have proposed that the combination chosen is adapted to the patient's differential diagnosis, comorbidities, and other therapeutic approaches and response to treatment. I would say this approach is far too complicated because it has a lot of assumptions in it that can't necessarily be appropriately tested, right? And if you want more information on that, if you go back through the library of the Osteopathic Lyceum podcast, you'll find that. Arguably, to read again, clinical reasoning in osteopathy may be underpinned by these models of structure, function, interrelationship, and within a continuum between practice and evidence from technical rationality, a practitioner-centered physical, biomedical, and biomechanical approach to professional artistry, a patient-centered behavior-based approach. I don't agree with that. The technical rationality being practitioner-centered physical, biomedical, and biomechanical approach versus professional artistry being a patient-centered behavioral-based approach. I would say that in actual practice, as a construct, you cannot separate that meaningfully. I understand that they're attempting to do that, but the artistry versus rationality is inappropriate because the application of osteopathy has no choice but to be patient-centered because of the barrier concept. You have no choice but to respond to how the patient responds to whatever physical interface you have with them. Otherwise, in a technical sense, you are no longer doing osteopathy because you are not considering the patient's response to your input. You are not trying to avoid the protective responses. In order to do osteopathy in a strict technical sense, you have no choice but to respond to the patient's response to the input because you're trying to avoid the protective mechanisms and the protective responses. So at no point does the technical rationality diverge from that because of that fundamental assumption that there's value in avoiding protective responses, not making them say ouch. So as a construct, I would argue that the technical rationality and the artistry have no choice but to coexist. They do not dissolve into separate categories or separate constructs because the patient is always at the center because you're trying to avoid the protective responses, which means you're applying the barrier concept appropriately. So I disagree with that fundamentally. So whatever then is built on top of that assumption means that they may be artificially generating competencies based on that dichotomous divergence that doesn't seem to actually exist, or I would argue doesn't exist. Yeah, to read again, we propose that the goal of clinical reasoning in osteopathy is to identify, prioritize, and deliver osteopathic care through a critical application of these 5 osteopathic models. I would argue not, because those models are just thoughts. They are not necessarily appropriate responses to how the patient is responding. Those are how you interpret things after you find them. And applying them in application, regardless of the model that you use, you still have to put your hands on the patient, you still have to move the patient, and you still have to respond to that patient to avoid the protective mechanisms and the protective responses. So I don't agree with that. This may be achieved through a multi-stage reasoning, to read again, this may be achieved through a multi-stage reasoning process that usually begins with a biomedical approach to identify red flags for serious underlying pathology and culminates in specific osteopathic diagnostic approaches that include the judicious use of palpation. Diagnostic palpation is an important part of the osteopath's clinical competence profile, and together with critical evaluation of osteopathic principles, plays a significant role in osteopathic clinical decision-making processes. Again, as far as identifying red flags, absolutely. If you want to call that a biomedical approach, you can. I don't think that's a biomedical approach. I think that is more of an approach that is based on medical ethics, right? So non-maleficence and beneficence would underpin that, and they may be more appropriate categories such that there doesn't necessarily need to be a division between the biomedical and other models, or the biomedical model and the osteopathic model, because through healthcare ethics or medical ethics, non-maleficence and beneficence guide us more than whatever we would want to build on top of that, as constructs anyways. And I'll read this as well. It has been argued that the specific structure function to relationship models grounded in osteopathic principles differentiates osteopathic clinical reasoning from other health professions and enable osteopathy to be regarded as a health profession and not a technique. I don't know that I would agree with that, again, because the structure function interrelationship models, the models themselves, the biomedical, the behavioral, the circulatory, respiratory, or whichever one you want to talk about, the neurological, those again are post hoc rationalizations or interpretations based on findings of structures that you can't appropriately interface with to make accurate claims about them. You are getting information by proxy from the outside of the patient, such that using those models has more opportunity to be wrong than be right. If you are looking at the motion of the patient and interpreting that, then that's the most accurate thing you can do. And anything that you interpret more than the motion finding and the motion change, you're making assumptions that gives you more opportunity to be inaccurate. So osteopathy, again, the thing that I would argue differentiates it from other healthcare practices is the actual application of the barrier concept and avoiding the protective mechanisms. So again, there's divergence from what they are saying versus what I seem to observe. But I completely understand the rationale why they're going this way, because it's going towards a regulatory process, and the people who would be placed in that regulatory process to judge it and to guide it would have experience with other things prior to that. So they're looking for similar stuff and similar processes. Experts working group. I'll just look at some of this really quickly. Yeah, just really quickly to read some of the competencies, and this is function 1, health promotion and prevention. So they're setting up general categories that they would consider containing competencies to overall lead towards a framework to judge competence. So function 1, health promotion and prevention. The osteopath must be able to recognize within an interprofessional collaborative team the biopsychosocial context in order to identify risk factors for health. Biopsychosocial, if you look back through the library of this podcast, you'll see the problems I have with that, because it's kind of a no-duh. It is not a theory, it's not a hypothesis, it's a model. So no-duh, yeah, there's biological, psychological, and social factors. If you are able to identify psychological and social factors that are the primary rationale for the patient's presentation, then you immediately know as an osteopathic practitioner that your interventions are far less likely to impact the patient, because you're really working more on the physical side, aka the biological side. So if there's no biological finding or movement-based finding, it is far less likely that you are going to meaningfully, reliably impact anything towards a health state, because you can't make a meaningful change with your skill set. So it's really just telling you who you're unlikely to help. To read on 1.1.1, recognize the centrality of the person in the healthcare system and health promotion. The barrier concept does that. 1.1.2, establish a symmetrical relationship between osteopath and the community in order to raise awareness of healthy lifestyles. That's health promotion. Fair enough. 1.1.3, encourage community to express its ideas and about possible health promotion practices by involving it in decision-making during the development of a long-term self-promoting health plan. This is where we're definitely getting into administrator stuff. You want an osteopathic practitioner who is going to have their primary skill set in physical interfaces, talking to people about things outside of relatively passive physical interfaces. But this is because they're used to this, laying this over other health professions. Don't necessarily need to go through that. 1.3, let's look at 1.2. Educate the community to develop healthy behaviors. Osteopathic practitioners are probably not the best ones to do that by training, especially if you look at the WHO document, they're not going to be experts in health promotion. And there's going to be a lot of orthodox positions contained within health professions that maybe don't actually promote health as much because of external factors. So long-standing concepts may not be the most appropriate concepts. So you're going to run into those. 1.3, promote community empowerment. This is like the health advocate role in the CanMeds framework. Promote health through an osteopathic manipulative treatment focused on adaptation. 1.5, educate the community to identify variations in its adaptive capability. I'm not 100% sure where they're coming with that. Motivate the community to practice exercise and adopt a healthy eating lifestyle. This is probably inappropriately placed upon osteopathic practitioners. There are other people who are probably better served for this. That's fine. Function 2, the osteopathic care. The osteopath must be able to base clinical reasonings on osteopathic principles and models. Well, if they have flaws, then whatever competency you build on that can have flaws. I would argue that they do have flaws. 2.2, identify health needs. Welcome the person and any caregivers considering the family and social context. Identify the person's requests and expectations. Yeah, sure. 2.3, collect useful elements for osteopathic evaluation. Yeah. This is just breaking down into a lot of stuff that you would see in the CanMeds framework. Osteopathic care, got that. Table 3. Whoa. Nope. Therapeutic education. That's the educator role. So in the CanMeds framework, there is an educator role, there's a patient advocate role, things like that. So these roles very much are in line with what has been done with competency frameworks around the world in medical education and medical regulation. So completely understandable when there's a regulatory framework coming again. My argument is that some of what is built in order to have similarity to previous processes may be inappropriate for osteopathic education and osteopathic practice on account of what I would consider likely more limited skills as opposed to what's being asked for. Generally, when a regulatory process is going to come in after others exist, you're going to have to piggyback on what already exists. The kind of quick snap of the fingers and automatic approach is, hey, there was already this healthcare thing, let's use it. Well, we want healthcare professionals of any ilk to promote these things. Well, if they're not properly trained to do so, they don't have the proper psychological training with respect to behavior change and application of that in order to get people towards the most appropriate healthcare behaviors or healthy behaviors, then it's inappropriate to request that they do it because they're not properly skilled in most jurisdictions. I would tell you that osteopathic practitioners are not going to be properly trained and properly skilled to do that stuff. Using the biopsychosocial model, it's kind of a no-duh. It doesn't properly respect what osteopathy actually already contains and how it already contains that. The biopsychosocial model really just tells you the limits of, or would help you cognitively interpret when you're at the limit of meaningful benefit of your intervention. Osteopathic practitioners nowhere in the world are properly psychologically trained. It would likely be inappropriate to ask them to be. It would be very appropriate to ask them when they are at the edge of the biological opportunity for intervention that they refer to psychological and social care. So what I will say is that I think what is contained in the article as the proposal for a competency framework is strong. It is well done, especially within the context that it lives. I would argue that the fundamental assumptions of it could probably be adjusted, and I would argue that as we go forth as a profession, we should likely reconsider from bedrock what we actually do, try to identify that, and build things on top of that, as opposed to simply scabbing this and scaffolding off of something that previously exists. Understand what the point of a competency or identifying competencies is, and appropriately build them from scratch for osteopathy, as opposed to just saying, hey, that looks really cool over there, let's import it and change the words to suit us. It's probably not the best way to do it. So thank you for listening this far. I appreciate it. Hopefully you learned something from it, and we will talk again soon.